had actually been involved with the pain clinic on the other side. I had brought a patient into the program who had been referred there. It was a work comp case. So the whole process, it went on for a couple of weeks, and the more I was there, the more I was impressed with the program, and thought, boy, this would be a great place to work, because I'd already been working with chronic pain patients through workers' comp. And so then when the job was posted, I was thrilled to see it and thought, oh, here's my opportunity. So I applied for it, and fortunately they remembered me. And I think because I was able to get a patient admitted within 15 minutes, because the admitting office called and said, we want to get her, we got a bed for her, but we don't have an authorization yet. And so they contacted me to see if I could do anything as far as getting that authorized. So I was able to do so in 15 minutes, and that was part of what they were looking for, was someone who could say no, felt comfortable saying no, and there were a number of times where I did have to say no, we can't approve that service, and also that the way I was able to expedite getting services for the patient and pulling strings to make sure she got the best care possible.
And for me, I've spent about 17 or 18 years of my social work career working in a medical setting, doing both social work as well as case management on a variety of medical services, all the way from the emergency room to the intensive care unit, to skilled nursing, to acute rehab. And I also worked on multiple inpatient psychiatry units. So I was really looking to continue with a position that was going to combine both my skill sets as a social worker and case manager, as well as to bring together both the medical piece as well as the psychiatric piece, which goes well with the pain clinic.
And that's part of our role, is to help out with dealing with the insurance companies. One of the issues with patients in any clinic, but also the pain clinic, is getting certain treatments or services approved. And so we're the go-between now of dealing with the insurance company, finding out from the doctor what they want to do with the patient as far as their treatment plan, and then we deal with the insurance company about trying to get that approved. And we deal with Medi-Cal, we deal with Medicare, we deal with private insurances, we deal with workers' comp, we deal with the veterans insurance, TRICARE, I'm sorry. And so we're pretty much advocating for the patient with the insurance company, finding out what's covered, pushing for something to get covered if they say they don't usually. And there's different negotiations we can do as far as getting the treatment the patient needs by working with the insurance company.
We also work with the patient and helping them understand what their insurance covers and will cover, and this comes down to a lot when we're assisting patients in getting connected with mental health resources. So we'll help them understand their benefit in terms of what levels of care they're able to receive, how many sessions, and as well as sometimes this comes into like the physical therapy forum with Medicare, as to how many Medicare sessions they can have and use, and where they can go through Medicare. So really helping patients to understand their insurance benefit and know how to navigate it.
You can now.
Yeah.
I'm sure there's universities all over the country at this point now, but there is one like in the Bay Area called Samuel Merritt, where you do have to be a nurse already before you go into the program, but you do come out with a degree in case management. Unfortunately and fortunately, the title case management is used interchangeably with a number of organizations. I was a complex care case manager at another organization in the Bay Area, and it simply meant that I worked with patients that had 3 or more comorbidities. Where at Stanford, the title means that it's a hybrid, kind of a hybrid position of social work and case management. So again, Karen has her degree in social work, where I have my degree in nursing and have worked as a case manager, and then I'm now board certified in case management since 2001. So I have had enough experience that I qualify for that credential and plus pass the test.
And for me, in terms of getting an advanced degree, social work always combined both the therapeutic approach as well as a case management perspective of linking people to resources and services. So that's how I became, qualified to be a case manager, is doing.
You can now. I'm sure there's universities all over the country at this point now, but there is one like in the Bay Area called Samuel Merritt, where you do have to be a nurse already before you go into the program, but you do come out with a degree in case management. Unfortunately and fortunately, the title case management is used interchangeably with a number of organizations. I was a complex care case manager at another organization in the Bay Area, and it simply meant that I worked with patients that had 3 or more comorbidities. Where at Stanford, the title means that it's kind of a hybrid position of social work and case management. So again, Karen has her degree in social work, where I have my degree in nursing and have worked as a case manager, and then I'm now board certified in case management since 2001. So I have had enough experience that I qualify for that credential and plus pass the test.
And for me, in terms of getting an advanced degree, social work always combined both the therapeutic approach as well as a case management perspective of linking people to resources and services. So that's how I became, qualified to be a case manager, is doing.
How having case managers, social workers involved in a pain clinic setting has been very beneficial from our point of view, knowing how we can help, but also from the staff's point of view that that we're able to intervene in so many different situations that they've never had that kind of support before. And it's fortunately improved patient satisfaction, patient outcomes, and just generally we're there to be a huge support in situations that they really didn't have any in the past. So it's really worked out well that they made a choice to create these 2 roles.
And for me, one of the things that I really notice with our position as well is we often do these multidisciplinary evaluations where there is a lot of recommendations given to patients. And in the past, patients would go home with these recommendations and we wouldn't really know what might happen with these recommendations. Now, Susan and I are often involved in those cases in following up with those patients and ensuring that they get connected with these services, or if there's barriers to getting connected to these services, that we're able to help get through those. And so with that, we have more successful treatment plans.
Mm-hmm. I call ourselves the gap fillers. In the past, patients would go home and then they'd say they'd never hear from anybody again, and they wouldn't have the motivation to follow up with what the treatment recommendations were, and we kind of are that nudge and follow-up call to say, were you able to find this type of provider yet, or do you need us to help you with that? I've had patients, especially younger patients, who will be afraid to admit that they use it. And so part of my role is to give them a safe environment to talk about it and without any judgment. And while our doctors can't prescribe it because it's hard to determine the efficacy of it for the general population and how much of a dosage each person is taking through the various forms that you can use medical marijuana. So we don't usually, my feeling is if it helps the patient, then be supportive of it. And my first experience of it was working on an oncology unit where they'd be terminal and horrible pain, and if they started using it in their room, we just closed the door and just didn't, we weren't going to tell them no, and we weren't going to make it obvious to the rest of the patients that somebody was using it because it helped them with their pain, and we wanted them to be as comfortable as possible through the end time. And so I think too, with our patients now being in the chronic pain field, that if they've tried everything else and it's something that does help them and the doctor feels that it's safe for them to use it, then I'm okay with it.
Similar to Susan, since we don't prescribe that through our clinic and we feel that there's not yet enough research to back its efficacy with pain, kind of limited in that area in terms of having patients get connected with it through us, but I am quite aware that a large portion of our patients are using medical marijuana, and I'm kind of the mind if it works and it's helpful for you, then I think that you should do it as long as it's not harming you. So I like to provide a forum where patients can talk about what they're using for their pain. I don't like to provide any judgment or shaming or anything around it. So that's where I stand with it.